So we're going to talk about emergencies. So you have something called meconium stain amniotic fluid. What happens with meconium? Babies pass meconium stools before birth. That meconium sometimes looks black, but for the most part it's green. It can be thin or thick, and there's actually 3 reasons of why the meconium is passing, or the reason for meconium. It's normal. Usually babies pass meconium. It's kind of infrequent. It's usually before 23 or 24 weeks, and then it will increase after 38 weeks. It will also happen with a breech presentation. And when I'm talking about meconium fluid, I'm talking about that you're seeing meconium stain fluid when you're assessing the amniotic fluid. It looks green. The other reason is a result of hypoxia, and the other reason could be an umbilical cord compression. The biggest risk, though, is if you see meconium stain amniotic fluid, is that the baby is at a risk for meconium aspiration. And when they get meconium aspiration, they usually end up with aspiration pneumonia, and they can also end up with sepsis from that. So what do we want to do? How can we manage it? Because you can't really treat it. You can't make the meconium go away. So how can we manage it? It used to be at one time, standard deliveries, head would come out and they would take the bulb to the throat and the nose. There is something called NRP, which is neonate resuscitation protocol. This is not something you guys have to know. And they are like the Heart Association of the CPR world, except they're specific to neonates. If you do work on mother-baby, labor and delivery, or if you're a respiratory therapist, you have to have NRP. So they decided we don't need to routine suction these babies' mouths and nose. We kind of need to know what baby does. So the protocol on how to treat the baby with the meconium stain amniotic fluid or manage the baby is based on the baby's condition at birth, whether the baby cries, lethargic, or whatnot. So that's just kind of a little brief overview of meconium stain amniotic fluid. We'll talk more about meconium when we get into the newborn. So now we're going to talk about shoulder dystocia. What shoulder dystocia means is the head's born, but that anterior shoulder can't get out from underneath the pubic arch. This is where the babies are at very high risk for a brachial plexus and different birth injuries. One of the reasons why a shoulder dystocia may occur is because you have a macrosomic baby that is, remember, greater than the 4,000 grams, and or mom's maternal pelvic is not adequate for delivery of this size baby. So what are complications? Complications for baby: trauma, brachial plexus. They can also have a fractured humerus or clavicle. The most serious complication is the brachial plexus, and this is what they call Erb's palsy. This can also result in intrauterine forces during the second stage of labor. This occurs not because of the maneuvers. At one time, there are maneuvers that we're going to talk about, suprapubic pressure and McRoberts maneuver. There was at one time they said that those maneuvers caused the shoulder dystocia or caused the injury to the baby, and according to your textbook and research, that's not the case anymore. For mom, maternal complication for her is postpartum hemorrhage and rectal injuries. So what can we do to manage it? You can do something called suprapubic pressure. There is a picture, I believe, on the next screen that shows you that actual process. What does that mean? Mom's legs are flexed apart with her knees, and Mom's legs are flexed and her knees are on her abdomen. Sorry. This way, what happens is the sacrum straightens and the symphysis pubis actually rotates towards the mother's head. So then suprapubic pressure is applied, helping shift the shoulder out. That's the goal of applying that pressure and repositioning mom to help expand as much as we can expand so that baby shoulder can come out. McRoberts maneuver, which I think is the slide, yes, after the suprapubic pressure slide, so it's 2 slides down, is where mom's usually getting an epidural. It is the preferred method. You have the mom move to a hands and knee position. They call this the Gaskin maneuver. And it just simply means hands to knee. They love to come up with these crazy names so they can put those in the questions instead of just saying hands to knee. So Gaskin's maneuver, hands to knee position, and then what will happen is fundal pressure is actually applied, which relieves the shoulder dystocia and hopes to maneuver the shoulder out with this particular position. So it's the same concept as suprapubic pressure, except we're not applying direct pressure to mom. We're repositioning her so that she can actually accommodate the shoulder movement. One of the things your textbook notes is the Gaskin maneuver requires that the mother is mobile. She can't be having an epidural or any type of things that inhibit her movement and then try to get into a hand-knee position, because it's not safe. It's not safe for her and it's not safe for baby. Okay, now we're going to talk about a prolapsed umbilical cord. What does this mean? This means the cord lies below the presenting part of the fetus. The umbilical cord may be hidden and not visible. So at any time during labor, whether or not the membranes are ruptured, this can occur. What do we want to do? We need to do something quick and fast. With a prolapsed cord, if you go in to assess your patient and your patient's like, oh, I think my baby's coming, and you pull back the curtain or you pull back the drapes or the blanket or whatnot, and you look down and your baby's not coming because it's not a head and it's a cord that's dangling, there's some things you have to do. You have to put on a sterile glove. You have to put on a sterile glove and stick your finger in there, and yes, you do, and you have to relieve the pressure on the cord. Sometimes it actually requires that you stay in that position and you are calling for help. You're not leaving the woman. You do not leave her by herself. Absolutely not. You do not remove your hand and take that pressure off. That's detrimental to the baby. You can also assist her into a modified Sims position, Trendelenburg, or most of the time it's the knee chest position to help alleviate the cord. This is a picture of the different ways the cord could be actually prolapsed, and it's from your textbook. If the cervix is fully dilated, they could use forceps or a vacuum assisted birth can be performed as long as the baby's in a cephalic position. If not, this mom's having a C-section. So, what are some signs and symptoms? They may actually have a prolonged deceleration during a uterine contraction. She may actually feel the cord after her membranes are ruptured, or you actually see or feel a cord protruding from the vagina. This is all from your text box that says emergency on page 479. Interventions, call for assistance. Do not leave her alone. Someone needs to notify the physician. You are putting a sterile glove on. and inserting 2 fingers into the vagina to the cervix, and with 1 finger on either side, you are actually holding the cord or the pressure off the cord. You do not move your hand. You can have another person roll up a towel and put it underneath her hip. That just kind of helps reposition her a little bit to help kind of gravity take some of that pressure off also. We talked about the positions that we could actually put her in. Oxygen. You're going to place oxygen on mama. She has to have oxygen delivered 10-liter mask. Why do we have to put 10 liters on via mask on moms versus a 2-liter nasal cannula? We have to do that because we have to get enough perfusion through mom, through placenta, through baby. So anytime when you see labor and delivery for the most part, or antepartum, it's via mask, 10 liters, oxygen. IV, she's going to have IV fluids. We need to start an IV on her, or they're usually going to increase the drip if she already has currently an IV running. We're going to assess fetal heart rate. Okay, we're going to talk about the amniotic fluid embolus. This is something that is sudden, it's acute, onset of hypoxia, hypotension, cardiovascular collapse, and coagulopathy. This occurs during labor, it can occur during birth, it can occur within 30 minutes after birth. It's a combination of sudden respiratory and cardiovascular collapse, along with coagulopathy. They present with the signs and symptoms of septic shock. This happens because a foreign substance is introduced into the circulation, resulting in DIC, hypotension, and hypoxia. With amniotic fluid embolus, the exact factor that actually initiated it has never really been identified. Some of the risk factors: advanced maternal age, minority race, placenta previa, preeclampsia, a forceps assistant, or a cesarean birth. In the emergency box on page 480, there are signs and symptoms and the interventions in regards to amniotic fluid embolus. Some of the interventions we're going to oxygenate. Remember, 10 liters, mask. They may have to have intubation, mechanical ventilation. They may have to have CPR. We want to maintain cardiac output, replace fluid loss. We want to correct any coagulation failure and prepare for an emergency birth if this is something that's occurring prior.